97% of all drugs ever invented were for symptom management, not for curing anything. So our healthcare system is focused on managing symptoms because there's a lot of money in that. Let's face it, it's a repeat business. If you don't fix them, they're going to keep buying the relief. What we need in our healthcare system is something to make a functional correction. Colleen mentioned how they caution us, oh, your treatments, you don't want to be excessive. Well, you look at medication. In 2016, Consumer Reports ran an article and looked at the last 20 years, and they were concerned that the amount of prescriptions written in the United States in that 20-year time period went from 2.5 billion to 4.5 billion. That's an 85% increase when the population only grew by 21%. By 2024, we're now at 7 billion. There's nobody putting the brakes on the medication. It's the brakes on the things that actually fix people.
I'm Garrett Salpeter, and I believe that the most powerful and transformative way to help people recover from pain and injury, heal from trauma, and reach their highest levels of fitness and performance is to focus on the nervous system. In this podcast, we'll share knowledge from the frontiers of neuroscience and inspirational stories of how applying that knowledge has empowered people from all walks of life to heal, adapt, and grow. Hello, NeuFit Nation, and welcome back to the Undercurrent podcast. I'm joined today by some recent friends, Dr. Mike Carberry and Coleen Carberry. So we have a chiropractor and a physical therapist married to each other and co-founders of Advanced Medical Integration, which is a company that trains practitioners, practice owners in how to run an integrated practice like they had when they were practicing together and came up with the different elements of this model. And I love their practice model so much that I asked them, and I'm grateful they said yes, asked them to come on the show and talk about the work that they're doing at AMI. And they're doing what I would describe as a very holistic kitchen sink approach, which, as you've likely experienced, there are many times where patients and ourselves alike, have these chronic conditions, and just trying a little bit of this, a little bit of that, treatment-wise, isn't necessarily going to be enough. It takes a longer-term concerted effort to really have a real solution, to create a real solution, lasting positive outcome. And I really like their philosophy, and am excited to welcome them both on to talk about their work. So Dr. Mike, Coleen, welcome.
Thanks, Garrett. Nice to be here.
Thank you, Garrett. Thanks for having us.
Heck yeah. So can you start out by telling us a little bit of your origin story, and I guess whoever wants to, let you self-select who wants to.
I'll let Mike start. He can start with the origin story. Where did we start?
So I graduated undergrad school in 1983 with a marketing degree, and I got hired by a company that was owned by Dun & Bradstreet. That was my first job out of college, and that was the largest marketing company in the world at the time. And I started off in that environment. And I met Coleen a few years later. We started dating. She was a physical therapist. I was not anything to do with healthcare. I had no background in healthcare or anything. But while we were dating, I had a neck injury. And the neck injury was serious enough that I went to the emergency room because we thought I broke my neck. I had experienced some temporary paralysis for a very short time, but enough to scare the crap out of me. And so I went to the emergency room, and the doctor told me, after looking at x-rays for a couple hours, you didn't break your neck, but here's some medication and good luck, because I was still experiencing pain and some problems with my right hand. And long story short, after taking medication for 3 weeks, I realized that wasn't going to take me where I wanted to go. And I decided to go to a chiropractor. And Coleen was concerned because she didn't know anything firsthand about chiropractic, so she went with me, and that's how it all got started. Not only did I get fixed from my problem, but I had headaches before I had the injury, and I realized that was part of the thing that set me up for the injury. But the headaches went away, and I never even told the doctor about the headache. So I was like, oh my gosh, it was like I got this huge epiphany. This is what I'm supposed to be doing. I need to go back to school, quit my job, go back to school, and start over again in a different career, which a lot of people told me I was crazy for doing that, but Coleen did not. When she saw chiropractic, I'll let her tell you what her experience was, but we actually decided to make a career together, trying to get the world under chiropractic care, and then expanded from various reasons along the way. I'll let Coleen tell her story.
Mm-hmm. Yeah, that's right. When he went to a chiropractor, we didn't know. The only thing I knew about chiropractic is what I was told in physical therapy school, which they didn't tell a lot. They would make comments. There was a lot of comments about, mostly derogatory about chiropractors. And so that's really all I knew. Okay. And so, when he hurt himself, I knew the medical system. And so I think when he went, and he actually got better. That's the other thing in the medical system is that, well, what about all the intervention that that's supposed to happen in all of this? It didn't, and you got better, kind of thing, you know? And so for me, it really opened my mind to the field of chiropractic. And I think when you went to school, Mike, in those 4 years, we moved to Georgia. He went to school for 4 years at Life University, and I worked down there as a PT. And I think as you went to school and I got more and more exposed to chiropractic, and then of course when we started practicing together, that was at that point, you know, when we started seeing patients, and I saw what what we would say is miracles, things that shouldn't have happened. You know, people's sense of smell came back. Things as a physical therapist you don't even consider, right? But things like that along with our care were happening. That just where we, you know, it's the definition of a miracle. And at that point, for me, I was unshakable on the fact that chiropractic and physical therapy belong together in the clinical setting. No question. You know,
I came out of a school that was considered a straight chiropractic school, which meant nothing but chiropractic. And I came out of school, actually, drank that Kool-Aid and I was buying that picture. But when I got into practice, my drive to build a practice, the average chiropractor sees like 100 to 150 visits a week. And I started doing 120 a day by myself. And practice grew and grew and grew. And we became one of the largest practices in the state of Pennsylvania. But what bothered me with that was people would get amazing results, and then they'd come back and say, you know, it's starting to come back a little bit, and I'd have to work on them again. And I'm thinking, why am I not getting like a done? Why am I not getting, okay, you're now fixed, go forth and, you know, have another problem, but not this problem? So when I started doing research on that through friends and through my research, I came upon a guy named Vladimir Yanda, who was a medical doctor who came up with a series of exercises. He looked at, you know, when people have chronic degenerative arthritis, how they respond to that. And that is by far what most chiropractors see is chronic degenerative arthritis. And he said they start to alter their posture by leaning their head forward unconsciously to offload the painful part of the spine. And that creates what he called upper cross and lower cross syndrome. That's a pattern of imbalances in muscles. And when I read that, I was like, oh, this is what I was looking for. Now I know if I create a rehab program to correct the postural distortions, because when I got people, I wasn't getting them the day after they got hurt. I was getting them like 30 years after they got hurt. And so I thought, I'm married to a physical therapist. This is perfect. We could work together. Well, roadblock number one was the state of Pennsylvania told Coleen, the PT association, that if she took a referral from a chiropractor, they would take her license away. So we were not allowed to practice that way.
Yeah.
And so Coleen suggested, why don't we get an MD? And I did not want to do that, but then I didn't realize what she realized, that there's a lot of them that are holistic minded and wanted to see a less drug oriented approach. And that's how we got started.
Yeah. Yeah. Wow. You should tell a little bit of, or do you have another question, Garrett, before we move on?
I want to dive into this, a little more about your practice in Pennsylvania, which of course became the model for what you're doing now through AMI. So I want to hear more about that. So if you have more to say on that before my next question, please go ahead.
Sure. Well, go ahead, Colleen, if you had something you wanted to say about that. I could say more about it.
Well, what we did was in Pennsylvania, when we brought on a medical doctor, because we were so big, it wasn't like we just brought on a medical doctor and that was it, right? We had 5 chiropractors on staff. We had physical therapist on staff, physical therapy assistant on staff, and we ended up bringing on 3 medical doctors because we were seeing so many patients, right? And so the magnitude of patients brought on its own complexities. So we had to actually figure out, how do you see so many patients and give really good care? Like, that's what we had to be able to sort out. Because what happens is that a practice can resort down to giving the same, clinical model to everybody. Physical therapy, adjustment, and hot pack, E-stim, or whatever it is that was at the time, and everybody gets the same thing. That's the easiest way to handle something like that, and that's how most people do handle something like that, is they have like 1 or 2 items that they like, and everybody just gets the same thing, and they're what's considered high volume. And so, it's interesting because in the PT world, there's no such thing as high volume unless you have a lot of physical therapists. You know what I mean? Because the physical therapists, we learned to treat one-on-one is what we treated. So you had from 9 to 10, you had maybe one patient from 9 to 9:30, one from 9:30 to 10, and one, kind of thing. You weren't double and triple booked. But what we said was, like, because we were already big as a chiropractic practice, seeing over 750 visits, when we brought the medical team on, we weren't going to just drop down to 100 visits, you know what I mean, and go into that model. So we had to figure out how do we do this, and that's, I think, we took, well, what we basically looked at, we said, well, if you look at a hospital system, they certainly see a lot of people at one time. So what are they doing over there to be able to see a lot of people at one time? Now, mind you, maybe the treatment that they do might not be aligned to what we do, meaning, drugs and surgery, because our belief is that conservative treatment first and then give drugs and surgery later. Because, we're not in a life
if you need to.
If you need to. We're not in a life-threatening space. This is not, oncology, and this is not where somebody with a broken bone. We're talking chronic pain, basically, right? And so chronic pain with patients who've tried a lot of things. And so we said, okay, well, how do we actually see 500 or 600 visits a week that are actively under care, that all those patients need different types of treatment plans? Because no body is, meaning like the body walking around, is exactly like the next body. So you had to have a unique treatment plan with enough modalities or treatments or services to handle that person. And how do you do it in such a high volume way? And I can later talk about the clinical side of it, what our thought process is. But in this sense here, this is when, Mike used to watch me as a PT go to team meeting, right? Because my background is traumatic brain injury. And so in that, I was always on a team. And my whole career, I did traumatic brain injury. And then I worked, acute care at times and outpatient at times. When he was in school, I did all kinds of odd jobs, right, on the side to make extra money. But I was on a team. My full-time job was on a team treating traumatic brain injury patients and coma patients. So I said to him, we should bring the same concept in, because these are super complicated patients. And the way we were able to treat them and keep us all on the same page is that once a week we got together and we discussed the case and made sure we were all on the same page, and the doctor wrote the orders to keep us all on the same page and to make sure the patient was getting better. And we said, well, why is this not in an outpatient setting? This type of collaborative treatment is only in, like, for severe cases. You find it in oncology hospitals, on oncology departments. You find it in head injury, brain injury, spinal cord injury centers. You find all this collaborative care in that type of setting. And we said, why do you have to wait to get bad enough for everybody to be coordinated on your care? Why can't we have a staff of PTs, massage therapists, PT assistants, chiropractors, medical doctors, and coordinate care in an outpatient setting, and the patient never has to get bad enough to need that coordination of care? And that's when the idea was born for us to put a team meeting in place for our patients, because there was a lot of patients and there was a lot of running around and running into each other. And that was when we implemented that, we never looked back. We were able to order customized care, like individualized treatment, and deliver it in such a way that our patients got the results and got their functional abilities back.
I knew that we wanted to have systems in place, because if we were going to grow big, coming from my background that I came from, I worked for a very large company and they had systems in place. So we had to figure out those systems. We had to figure out a way to measure somebody's problems and then to reevaluate every 2 weeks or so to see that they're getting better, and then how to know when to discharge. So we had to put all that together. And we did that in Pennsylvania. And once we learned how to do that and we created the systems, we opened up 3 practices in the state of Tennessee in the year 2007. And we never lived in the state of Tennessee, and all those practices are still going.
Mm-hmm. Yeah.
So there's a lot here to unpack. I have two questions that I think our audience may be wondering about, and there's just a couple details before we kind of move on to the next phase of the conversation here. So one is, as a chiropractor and a physical therapist, what was it like hiring a medical doctor to work for your business? Because I think people often believe that, MD stands for medical deity, and they're sort of like
I've never heard of it before.
The gods and stuff like that. So I want to hear a little bit more about what it was like, hiring a medical doctor. I know you mentioned you will find some who were philosophically aligned, which is great. Also, just kind of the interpersonal and the dynamics of, an MD working for a DC, sort of what that was like. And then hear a little more about the team meetings as well, where if you're seeing 750 visits a week, that, if 3 times a week, that's 250 patients, how are you talking through that many? So hear a little bit about both, but let's talk about the MD dynamic first.
So I could definitely tell you about that, because I didn't think we were going to have any apply for the job. And Colleen was like, no, there's a lot of them that are like, they don't agree with the traditional medical system. They think we're over medicated. So I didn't realize there was a mild upheaval happening in healthcare at that time, and it was with family practitioners. Family practitioners were getting their codes changed from time-based codes to E&M codes, meaning evaluation and management. You get a flat fee no matter how long you spend with the patient. And so it was forcing these doctors to rush through the visit. And since that time, this was the mid 1990s, since that time, we've lost probably close to a 500,000 family practitioners in this country, which is why we have 300 or 450,000 nurse practitioners now, because they're filling that void. But that's who was applying for the job. We put the ad out, and we had hundreds of MDs apply for the job. Now, we didn't have hundreds come in and interview, but we probably had 75 come in and interview, and we did them in group interviews because there was too many of them. And I thought, there's no way I could possibly interview one at a time this way. So we do group interviews, tell them what the clinic was about, and then if they wanted to stay, they could stay for the interview. We had quite a number stay, and so it was the exact opposite of what we expected. I expected that medical deity to come in looking down their nose, and if they came in at all. We had guys come in and going, I'm so sick of healthcare. I'm sick of the way things are. If this doesn't work, I'm quitting. And I was pretty floored at that. So we ended up picking 3 great MDs. Their philosophy perfectly meshed with ours, and it wasn't hard to find that in that group of people. When I started working with MDs, I realized, the reason somebody decides to go to medical school 80% of the time is because they want to learn how to help people, but they get into a system that is geared to sell medication, and it's not necessarily always to help people. It's to keep that industry flourishing. And so that's why we had this big exodus happen at that time.
Yeah. It's interesting, Mike, because I know when we talked about this back then, I never really thought about this, but, when I went to PT school, I went to Marquette University in Wisconsin. And then, of course, we did clinicals. And I did my clinicals at Henry Ford Hospital in Detroit. Okay. And I was in a dorm. This is such an offside story here, right? So they had, because it was a teaching hospital, Henry Ford Hospital in Detroit is huge, and it's a teaching hospital. They put all the students it was an old hotel that was refinished, right? But that's where all the students were. So I was in the hotel with the radiology techs, the PT students, and the med students. Okay, so we would have to take buses over to the hospital and back and forth. And then, of course, on the weekends, we hung out with the med students, right? Because they were there doing their internship, or whatever it's called when they're doing their clinicals or whatever. Anyway, so I, for me, they were just normal people wanting to help people, like Mike said, right? That later did get their degrees. And then once I graduated and I was out, in an inpatient setting, I'll be honest with you, the physiatrists are so grateful and respectful of the PTs and the OTs. I'm sure the speech therapists too, don't get me wrong. But what the PTs and OTs do for traumatic brain injury patients and comatose patients in an inpatient setting, they even know they couldn't do it. And so in team meeting, we would give our reports, and you can just tell that they were just so thankful and grateful for what we did out there. Because Garrett, have you ever been out on those rehab floors with traumatic brain injury patients?
I've visited once. I don't have the real experience. No.
Well, it's like a free-for-all. I can tell you that, because, comatose patients, when they come out of a coma, they go through stages, and combativeness is one of those stages they go through. So, your hair gets pulled, you get pinched, you get spit on. I mean, you get it all in there, right? But it's just like, we just would get in there and we did our jobs, and we were treated so well, the PTs and the OTs. So my experience, remember the doctors at Kennestone Hospital, because I worked at Kennestone Hospital, they were just so respectful. So for me, as I go through, and he was like, I'm not sure about these guys. I'm like, God, they're normal guys. I saw them in med school. You know what I mean? Just putting it all together. And they love what we're doing, kind of thing. So yeah, so I think when they came on, we had this consideration of just like, hey, we need your expertise on our team. We're doing great things, but your expertise just takes us to a whole new level, kind of thing. So, but it is interesting because our clients can have that same viewpoint, which is they're talking to a doctor that's, maybe higher than them. Their license is higher and therefore is tougher to talk to. But so that's why I think for us, we did well with our MDs and our nurse practitioners and physician's assistants. We worked with all different types of medical people.
That's awesome. So yeah, I think there's a few takeaways from that. One is, regardless of title and education, we're all humans, and if we can provide an opportunity to meet the basic human need for contributing and doing work that's meaningful to us, there's something there. And there's many people as everyone listening to this knows, there's some people who want to own and run their own business, and there's some people who prefer to not have the stress and pressure and prefer to have more of a steady salary and work for someone else. And so there's ways where all of that can work together and everybody can get what they want and there can be a fit.
And Garrett, I think they were happy for us to take the stress of the practice, right, Mike?
Yes.
Yeah.
Yeah. They didn't want to own. The three MDs we hired did not want to own. And over the years, I found that the medical providers were less interested in owning the business and more interested in having an environment where they could help people.
Yeah.
Whereas chiropractors, it's a good thing that on both sides, but the chiropractors tend to be more entrepreneurial. When I was in chiropractic school, if you asked 1,000 students, do you want to own your own practice someday? Probably 950 of them easily would say yes. Mm-hmm. But that wouldn't be the same in a medical environment.
Yeah. That's a very interesting distinction. Hopefully that starts to open the minds of some people listening to this to what's possible there. So one other detail before we move on, because I do want to get to some of your clinical approach, which I find fascinating and effective. Can you talk to us about a little more detail about how you structure those meetings? When you talk about the team meetings and how that was one of the big breakthroughs that allowed you to provide quality and customized care even to such a high volume of patients. How do you, since that seemed to be such a key, how do you run those when you're talking about such a large volume of patients? What are some of the processes or strategies there that allow you to be more efficient?
Yeah. You want to go for that, Mike?
We have systems that each person's responsible for reporting what they are. It's very similar to when Colleen was doing head injury. So we have a case manager who comes in and reports this is what the patient complained about, this is where their history is, excuse me, the things they've tried to do for it in the past. Then whoever the provider was did the initial exam, usually the medical provider, will report that. And then because chiropractors are so good at reading x-rays, if x-rays are ordered, the chiropractor would report that. And then everybody would be contributing into the meeting, and the case manager was keeping everybody on task to do it.
Yeah. It's interesting because when I worked in the hospital system, the physiatrist, of course, was the head of the team because that is the MD license is the head, right? So, and in some of our doctors' offices, it's a nurse practitioner. It doesn't matter. The medical license is the head. Mike is right about this, is that each team member reports, because that's what we used to do. OT would report, PT would report, speech would report, right? Nursing would report. So everybody reports in their respective areas because we need to get on the same page, and the medical person's listening. Then the medical person would have just done their examination, the visit before a team, right? And so she's putting all the data together, okay? And then you're right, if there's imaging, the chiropractor is the most qualified to review imaging because they have a radiology degree, right? So they're going over the imaging. And the medical provider puts it all together, and then the medical provider will say the orders, will give the orders for the treatment of care, okay? Very similar to in the hospital. The physiatrist always ended the whole thing after listening to everybody. And it's like I said, the respect that they had for all of us on the ground was incredible. Same thing in this type of setting. The respect that the medical provider has for everybody who's out there, the physical therapist for treating and the chiropractor for treating. But they put their heads together, and then the medical person will dictate the orders. And that's just the way it is. But they've taken the input of what's happening with the patient. It's that team meeting that keeps the care individualized. It's not just one doctor walking around going, I think this person should do that and this person should do that. Because what happens then is when you get busy, like anything in life, you drop to the irreducible minimum, and all of a sudden care becomes cookie cutter again. So it's those team meetings that keep it that these are actually human beings we're working with, and we're keeping them from drugs and surgery. So we actually really need to understand who they are, what their goals are in life that they want to achieve, and what their body is doing that's preventing them from doing that. And I think we do that well in team meeting, Mike. I think we achieve that in team meeting.
Yeah. The thing that we found is the medical providers, although they had it within their scope to do a lot of this stuff in a physical medicine program like this, they weren't familiar with it. And they would come to me and they'd say, listen, where I was before, all we were doing was writing prescriptions, and I'm not as familiar with this. So I would say, well, would you be okay if I showed you some of the way I do my orthopedic exam? And they were like, yeah, that would be great. That's really what I was asking for. So they were very open-minded to that. And when we started collaborating together, as the medical providers took on this information, they were the ones that worked with us, which was not hard to find, were very glad to not be writing prescriptions. In fact, one of them came to me early on and said, I don't want to write any more prescriptions. And if one of these other two guys writes prescriptions, their patients are going to ask me for a refill, and I don't want to do that. So can we have a policy to not write prescriptions? And I said, I can't do that. That's outside of my scope of practice, but a medical director could. Would you want to be the medical director? And he said, absolutely. So he actually went into the other two guys and said, listen, I'm now the medical director, and here's what we're going to do. If they need a prescription for blood pressure, you send them back to their primary, because I don't want to write the refills. And one of the two said, good, me neither. And the other one was like, okay, I guess we could do that. So it wasn't an issue.
It worked out.
I love that. I love that.
Yeah. Because we are these offices, what our office was and AMI offices, we're in what would technically be the pain space, because physical therapy is in the pain space no matter where you slice it. Same with chiropractic. So technically we're in the pain space. So there are primary care practitioners to do all of that, which is why it's we're able to keep the prescriptions out of the space. We don't even need to write pain medications in the space, because there's plenty of primary care physicians that will write that pain medication. You know
and
what I
there's
mean?
plenty of things we can do to mitigate the pain as well. Like,
Correct.
for example, when you had your guy Matt come in and do the treatment to our staff, one of our staff has a back issue, and she went a week pain-free after she had one treatment from Matt.
Did you really? But
Yeah.
that's right. Matt came in and demonstrated the NeuFit machine for us. And
so for you listeners, yeah, Matt is a physical therapist on our team. So he was in doing a demo at the AMI office, several months ago.
Everybody got to take their turn and give it's so funny because you could hear people over there going like, because he's a physical therapist, giving their ailments over there. And then he'd set them up. Everybody had tremendous feedback. The feedback was tremendous. And people had all different issues and problems. And he worked with them and gave them some relief without drugs. I mean, that's the biggest thing. That's why the NeuFit machine fits so well within our model.
Right. I'm 64. I don't have neuropathy that I knew of. But when he did a treatment, he said, let me just show you what we do for somebody with neuropathy. Well, the next day I'm walking around the condo barefoot. And I said to Colleen, I can feel stuff on this floor I never felt before.
He's like, maybe I had a little neuropathy there.
Maybe I did have a little bit of neuropathy. So
I know.
That's awesome. Yeah. I love that. And I think everyone listening to this can start to see why we're so aligned and enthusiastic about what you're doing, because we certainly share that philosophy of having a strong desire to help people reduce their pain, improve their function without relying on drugs and surgery. And there's strong fundamental alignment there. And we have a few pieces so far. We have this piece that you've shared about how you're working together to sort of figure out the model in your original clinic in Pennsylvania. Yep. A model of how you provide good quality care to such a high volume of patients. And once you sort of nail it and scale it, you're able to then open up these other 3 practices in Tennessee that you can own and run without having to be there on site because you have the systems. So what are the key pieces of the ideal AMI clinic that, as this model evolves, and this, of course, foreshadowing, this becomes the model that you then teach and train others to implement now?
I know Colleen has a lot of those details. I just want to preface by saying this. In Pennsylvania, when I first started, the model for chiropractic was the more you see, the more you help, the more you make. So high volume was a big thing. And I was doing high volume, 750 visits a week. When we opened the clinics in Pennsylvania, in Tennessee, we realized you don't need high volume. There's people out there that really need help. You can help them in a prescribed or determined period of time and then release them as being corrected. And so we were seeing more like 150, sometimes 200 visits a week in some of those clinics, but mostly 150 visits a week, much more like a standard chiropractic practice. And those practices were extremely effective. We have 3 rules. 1, we got to improve the outcome for the patient. 2, we got to do it in a compliant way. But 3, it's got to be profitable. And they were very profitable. So we don't chase the profits, but if you have the other 2 things in order, you will have profits. So
yeah.
So
well,
Colleen, you want to.
What we learned was, especially when you touched on that, Mike, about that in Pennsylvania, right? We were high volume. Initially, when we were a chiropractic practice in Pennsylvania, he adjusted people. It was like hot pack E-stim chiropractic. That was it. And it was like everybody hot pack E-stim chiropractic. Then we added the physical therapy component to it. And then we added the medical component to it. And as we added each component to it, it took less time for the patient to get better. And seeing that high volume, if you're very low volume, you can't quite connect dots. But being that high volume, we were able to tell that we were able to go from whatever it was, Mike was maybe adjusting people like 70 visits, and we were getting tremendous results. When we brought on the physical therapy portion, it got down to like 50 or 45 visits, and we're like, we're onto something here. Letting two not modalities, but like chiropractic and physical therapy together actually compressed time for the patient, and they got better faster. And then when we brought the medical team on, it landed around 30 visits was average for people to get better because they were doing injections with homeopathic substances, hyaluronic acid into knees, things like that, right? And so we were like, okay, so now we're talking team treating, right? Because I said, I treated comatose patients and they got treated twice a day by everybody, 7 days a week. We said, you know what? It took people, say they were 45, 50 years old to get into the condition that they got in, right? The idea that it's going to take 3 or 4 visits to get out of that condition is not, it didn't prove out like here, because Mike was seeing people for 70 visits and their conditions were getting better. And then we got it down to 50 or 45 and then down to 30. So then we started looking at even closer going, well, okay. And this is where I think, Garrett, I talked to you about this before when we talked, was having been in business as long as we've been in and being clinicians, both of us being clinicians and doing our own intakes on patients. Okay. When I was a PT, not working with Mike, and I would work outpatient therapy and I worked on the acute care floors, like orthopedic floors, like I said, as my evening and weekends jobs, right? I saw people who just were repeating in the system. Like people who came in for back surgery, it wasn't their first, it was their second or their third. Okay. And it was a revolving door. Okay. In the PT, as an outpatient PT, I get a shoulder patient. I wanted to work on the neck because it was obviously the neck was involved also, but I wasn't allowed to work on the neck because the orders were only for a shoulder kind of thing. So it was very limited. And I said to Mike, I said, as clinicians grew within our model, a couple things became very real to us, which was that the healthcare system, and I think I talked to you about this, Garrett, if you see yourself as like a train, okay? Oh, I think we lost Garrett. I wonder if he went out. Can you see him?
I can't see him, but it looks like he's still there.
Oh, he's
still here.
Oh. Okay, good. So if you think of it like as a train, okay, of health, you're born and you get banged around and whatever, then you're 15 and you're fine or whatever. But, at some point there's some aches and pains and you do the different things. You might do some exercise and you might do some massage therapy and you might even do some physical therapy. And then you might go to the doctor and get a cortisone shot. And then you might have a medication, over-the-counter medication. And then you might try some ice and some heat. But as you age, I call it the train. Okay, the train to drugs and surgery. And when I say drugs, I talk about a prescription drug, right? And so as you're aging and and people will tell you, oh, I'm just getting old, right? And, Mike's famous line, if somebody says to you, my shoulder's really bugging me, I'm just getting old. I know Mike's famous line, which is, well, how old is that shoulder? And they'll go, well, 50. And he'll go, well, how old is the other shoulder? And they'll go, 50. And he'll say, well, do you have a problem with it? And they go, well, no. And he'll go, and it's not that you're just getting old. That's his famous line, right?
It's that one part of your body is aging faster than the rest, and you find out what that is, and that should be the quest of what you do. So traditional healthcare is.
I'm going to finish. Let me finish my train. So anyway, what we found doing intakes, because part of our intake process, and we teach clients how to do this. Patients have been fully indoctrinated into the medical system through Better Homes and Gardens, through TV commercials, the pharmaceutical company's education. You look at any magazine, a third of it is pages of pharmaceuticals. You got the pages that have the tiny little words on it, but the rest of it is like somebody with puppies and telling you this drug and this kind of thing. But this has been going on for 10s and 20s and 30s of years. There's generations indoctrinated into this, which is there's a pill that can fix everything. And people will say they don't want it, but it's the only thing that they know. Okay, so what happens is when a patient starts having a problem and they go to a doctor, right? The doctor is going to try something and see how they do, right? And so the famous line is, okay, we're going to try this and we'll see how you respond. Like, this is almost like ingrained in doctors and PTs and chiros and everybody. Let's try this and see how you respond. Well, of course, symptoms are the last thing to show up and the first thing to go. The problem has been there. And when the symptoms show up, it's that last little bit of the line. So when you try a little bit of something massage, it feels a little better. And then the person goes back to their life and then it comes back again. And I call this the train to drugs and surgeries because they're on this train and then they get off and they go see a massage therapist, 4 times or something. They're like, oh my gosh, I feel so much better. And they get back on the train. Now their condition never got better. They just felt a little better. Then they get off and they see their doctor and they get a cortisone shot and they get back on the train because the doctor says, how about we're going to try this and see how you respond. I think all of us can agree on this podcast. This is a famous line coming out of any clinician. Let's try this and see how you respond. right? Well, of course, the body's going to respond a little bit and they're going to feel a little better. And then they're going to go about their business. The thing is, they won't go back to that clinician. Why would you go back to a doctor who's tried something and it didn't respond? You end up in another doctor's office, or you end up at a massage therapist, or you end up at a PT, or you end up at a different PT or a chiropractor. So when you do an intake and you ask them, what have you tried for your condition? And you hear all of these things, you realize, let's try a little bit of this or some of this and see how you respond, isn't working for this person. And I think, Mike, you can agree with me, 99.9% of the people we see, that thought process, let's just try a little bit of this, or let's just try this and see how you respond, is not healthcare. It is
Right.
the train to eventual surgery or some drug to mask the symptoms until they deteriorate enough till surgery. And it's the pharmaceutical train. And they're in the business of pharmaceuticals. I can't knock them. They're in the business to sell drugs. They've built out a beautiful system that they have actually got practitioners to actually say these statements. Let's try this and see how you respond. And then what they do on the back end is they then hit you with, don't overtreat. The insurance companies will tell you, don't overtreat. According to your peers, I mean, we used to get these letters, according to your peers, you treat more than your peers. And if you don't correct this action and cut it back, we're gonna pay you less per unit. And that's what they would do to us. We'd get penalized for overtreating. And so most practitioners, because they're scared because they need the money, are going to go, okay, that's it then. I'll only see him for 8 visits because that's all I'm going to really get paid for. And I'm afraid they're going to take the benefits away. Medicare sends these letters out that you're overtreating. So now, and then mind you, now I've got a clinician who's just going to try a little bit, right? And I'm afraid that I'm going to be accused of overtreating and my benefits I'm going to get cut. My reimbursement check's going to get cut. So I'm not going to rock the boat. And now we have a system that actually is not treating patients. They're reactionary based upon what they've learned and what they've been taught to do. So at AMI, we were finally like, remember I told you we learned chiropractic, then you had physical therapy, then you had medical. The reality is the more you do for the patient, the shorter the time and the better the outcomes. That's when the idea was born, which is, okay, why doesn't a clinic have so many modalities just like a hospital? A hospital has a ton of things. Doesn't mean everybody has to get these things. Like a clinic can have a newbie device, right? Physical therapy, chiropractic, bracing, regenerative medicine, trigger point injections, all kinds of devices. It doesn't mean everybody gets everything. But because we now teach our clients, if you order 4, 5, or 6 things for a person, okay, our system will get it so that you can deliver these things and not forget to deliver something because there's such chaos because you're trying to actually deliver so many things. You can't do it all at once. And so if I take the idea now, which is you come into my office, Garrett, hopefully I'm not going to be too long-winded here. You come in my office, you have a low back problem. I'm going to ask you about your low back. How long have you had it? You know, the regular questions physical therapists ask, chiropractors ask, doctors ask, how long have you had it? You know, what have you tried for it? You tell me, oh gosh, I've had it for 15 years and I've tried, you know, physical therapy, chiropractic, injection, whatever, all the things you tried. Okay, fine. And then we tell them how we're a little bit different in that we recognize the body doesn't work isolated. The low back does not work on its own. The musculature, the paraspinals come down, right? They connect down into the hips, right? They connect into the hips and even down into the knees. And we say to them, you've had the problem for 15 years and you've tried all of this stuff. And we explain that the body's connected and we ask permission to ask about other areas of the body contributing orthopedic factors that could be contributing to the problem, which is causing the problem never to fix. And can we ask them questions? And then we discover they had a knee problem for 10 years. And then the other knee's been a problem for 7 years. And they've had a neck problem for 20 years. And now the person puts together how the system has failed them. And what we do at AMI is we don't say this to patients, but our thought process is you've stepped off that train in our office and we will not be part of the problem. We are not just going to do a little bit and see how you respond, right? We're going to actually evaluate your low back and give you a treatment plan that's going to handle it. We're going to handle your knees, both knees, and that neck. And that's how in our offices, we can have maybe 15 different services and modalities that we can pick. Okay, for the neck, we're going to be doing this, chiropractic care, physical therapy, whatever it is we order. For the low back, we're doing this. For the knees, we're doing this. We have a comprehensive treatment plan. This is as a PT, as a head injury PT, this is what we did. We treated the whole body, is what we did on a team. So in that concept with AMI, now I'm just going to kind of end off on here because I can, Garrett, I can get so excited on this. But Mike, do we get amazing outcomes with patients?
We do. And there's a couple things I want to add in when you're done, but we do get amazing outcomes. When you're done, I'll just touch
Yeah.
into it.
Yeah. So that's so for us, we're not scared of overtreating because, all right, we'll take the 8 visits paid, but then we're going to ask for cash from the patient, because when the patient realizes the train that they've been on for so long, and that getting back on by doing a little bit, they are going to end up on drugs and surgery, and they know they don't want that. Every patient, most patients we know somebody who's been touched by addiction. Either it's somebody, an immediate family member, or it's one family member removed, that the family was touched by addiction, and they know they don't want that. But they also know that they've been heavily educated by the pharmaceutical companies that you're getting old and you're going to end up on drugs. So when they come into an office who says, we're not okay with this, we're going to tell you what you actually need. Now you can say no, and you can say, I'm not paying for it. But we will not be one of those doctors that just does a little bit to see how you respond. We're going to give you the truth of what you need. And that's, I think, what makes AMI offices so different from all the other offices out there, and what makes AMI different from other companies that are in our space.
So if I could add a little bit in there, there's a bigger picture thing here that I always look at. And the reason that our healthcare system is the way that Colleen just described, which it is you look at drugs and you go, drugs, 97% of all drugs ever invented were for symptom management, not for curing anything. So our healthcare system is focused on managing symptoms because there's a lot of money in that. Let's face it, it's a repeat business, right? If you don't fix them, they're going to keep buying the relief. What we need in our healthcare system is something to make a functional correction. And you look at, Colleen mentioned how they caution us, oh, your treatments, you don't want to be excessive. Well, you look at medication. In 2016, Consumer Reports ran an article and looked at the last 20 years, and they were concerned that the amount of prescriptions written in the United States in that 20-year time period went from 2.5 billion to 4.5 billion. And they thought that was a pretty big increase because that's an 85% increase when the population only grew by 21%. Fast forward in the next 8 years, by 2024, we're now at 7 billion. So there's nobody putting the brakes on the medication. It's the brakes on the things that actually fix people. So by stepping out and saying, you know what, we're not afraid to educate the public, especially people that are facing a surgery they don't want to get, and saying to them, look, there's another way to do this. We're going to focus on fixing your malfunctions, not just get rid of your symptoms. We don't want you to have symptoms, but why do we want to give you a drug that could cause you to lose your life because you become addicted to it? To get rid of your symptoms. Why don't we fix the problem so the symptoms go away and stay away? And that's what AMI's basic core foundation is. Looking at functional correction, we had to come up with, how do we evaluate these people to know what's wrong, and how do we evaluate these people to know when they're fixed, and then discharge them. And that's what we do. And our model works extremely well. That's why we get miracles, because we have different viewpoints, medical, physical therapy, chiropractic all together, and the patients get a better outcome in a shorter period of time. That is what we should set out to create, not to increase the charges to make more money, but to go, what can we do to fix these people faster and get them so they have the maximum correction they could possibly get? And that's what the product is of AMI.
Thank you so much for listening to the Undercurrent podcast. If you're interested in learning more about how NeuFit and the Newbie can impact your life, please visit our website at www.new.fit, that's neu.fit, so you can learn more about how it might integrate into your professional practice, how you can use it as a patient, and you can also connect with our team there.
We covered a lot in this last segment here, and I think the biggest thing that I want to emphasize is that philosophy. You, Colleen, talked a lot about that, that typical notion of try a little bit, see how you respond, as opposed to, let's see this thing through to its conclusion. So I think that's sort of the biggest paradigm shift there. And then, of course, one question that came up along the way was, how do you do this in an insurance model? And I think you answered it when you said, well, we'll take what the insurance will pay for in the 8 visits, so that'll cover part of it, and we'll present this opportunity for a larger cash-based service. And you talked about some of the pillars being how you do your intake and evaluation, setting up the plan of care, having the different treatment approaches, different modalities, some injections, having kind of a whole gamut of tools and strategies you can pull from as appropriate for that patient. And then, of course,
that's why the various practitioners are important, Garrett.
Yeah.
Because each practitioner brings some skill set to the table.
Right. And then, of course, woven into all this is the education you provide on how to implement this. So I do want to get to that next. But before we do that, can you give us a little sense of what does, a typical, to the degree that anything is typical, right? But a plan of care look like then under the model? Because you did talk about, initially when it was chiropractic, for these long-standing chronic conditions, it might have been 70 visits chiropractic only. And when you add in PT, it's 50. When you add in some other tools, technologies, strategies, it gets down to 30. What's a typical plan of care looking like that your, AMI trained practices are going to be offering to a patient in this circumstance?
Well, you got to realize that all of our clients have their own practices, so they're going to decide their own thing. But the AMI model that we teach, that we suggest, it's a 3-time-a-week program, because if you're trying to change something in the body, it's the frequency that you do it that has the most effect. So doing it like once a week isn't going to have, it's like going to the gym once a week. Yeah, it might make an effect that day, but it's really not going to make major changes in your health. But if you go 3 times a week consistently, you will see differences. So what we're doing is we're using a 3-time-a-week model. It depends upon the age of the patient and how much degeneration and complicating factors, but you're looking at anywhere from a 6-week, 8-week, 10-week, or 12-week program. Medicare agrees with that. It says typical outpatient program should be 12 weeks, 90 days or less. So that's where our model falls into. And it's not because we're trying to follow any guidelines, it's because that's when we see the patient getting better. And we do have patients get better. We have, in our clinics, we periodically have a party for patients who hadn't been in a long time, and we'd get them to come back, and they'd say stuff like, yeah, I was recommended knee replacement 10 years ago, and look at me, I'm still doing the deep knee squats, and I never got a knee replacement. So, it was pretty exciting to see that kind of results, happening with our patients. And another one was my daughter and her husband just flew down. They live in North Georgia. They used to work in our clinic in Chattanooga, and they come down to help us train. And they said, getting on the plane, it's a small airport, Chattanooga Airport, their steps were coming up from the runway, and the guy in front of them was running his wife's luggage up and down the steps because she couldn't carry it. And he turns around to him and he says, "You remember me? I was a patient in your clinic. Remember my problem? Going up and down steps. Look at me." And it was like 10 years later.
When we were like, that's such a great story. That's such a, yeah. What we do, Garrett, is again, my PT background was open gym. We don't have curtains and we don't have rooms. Mm-hmm. We have a wide open gym. The chiropractic tables are out there. The big PT mat tables are out there. The newbie is out there. The computerized range of motion machine, everything is out there, except for we have exam rooms to do injections in, because they need to be in an exam room, and then exam rooms to do exams in. So there's privacy, right? And so we have a bell on the wall. I don't even know what that is. Is it a cowbell? I don't know what that thing is on the wall. Yeah. It's a bell. And so what happens is when a patient starts with us, okay, they decide care with us. We then actually take them over to the rehab floor. We introduce them to their treatment team. The treatment team orients them to the floor, which is what we role played this weekend. They get oriented to the floor and the expectations of them, because they are an active part of their rehab. They're expected to come back, put their things away, sign themselves in the back of the room, and get started on certain activities. We tell them the activities they can start on if it's ordered for them, right? And then someone's going to be with them, and then be with them to move them through their treatment, or be like, you can go over to the newbie machine and there's somebody over there to set you up, or whatever it is they're going to, right? But as the patients are progressing through there and they graduate, we actually have a graduation routing form, okay? We have a system for everything. So the graduation routing form is kind of like where a patient they've been evaluated by the practitioner, they've met their functional goals. That's how we discharge. They've met their functional goals, okay? So they meet their functional goals. We then we take pictures, they write a testimonial, and then we ask them to give the test, go out to the rehab floor and ring the bell, right? And they ring the bell, and everybody knows when that bell, we say, okay, listen up, everybody. Everybody knows there's going to be a win with somebody, because they're all on that floor together. They're all telling their stories to each other. I'm here because I'm going to do this, and I'm here because I want to do this, right? And they're all there supporting each other. And when one of their friends graduates, they all stop, and then they say, this is what I was like when I was here, and now I can do this. And a lot of times they're raising their arms or squatting down or whatever it is, right? And everybody cheers for them, because it is unlike healthcare, which is a place of quietness and restfulness, and you should rest and take care of yourself. It's a place of life. So open rehab floor, ring the bell of celebration. And that's the whole, even though they might be in a lot of pain, like if someone comes back in a lot of pain, we are very, don't get me wrong, we're kind to them, but people encourage them and say, I was like that when I came in, stick with the program because look at me now, I'm moving around. It's such an incredible environment. And they make these friends, the patients make friends with each other and do stuff outside of the clinic. So it actually is for me, and I'm sure for Mike too, love the setting, love working in it. It's like, to me, it's like you're giving them back their life is what you're giving back. And there's nothing better. There's no better business in the world than giving somebody back their life and what they want to do in life.
Oh yeah. And,
Right.
and if you're going to be, working day to day in an environment, to be in one that's energizing versus one that's draining can make all the difference in the world. So
yeah. There's no whispering behind curtains.
No.
I used to work in some outpatient clinics and I was like, why are we behind curtains here? You know what I mean? Like these are like people, able-bodied people coming in. I was like, well, you know what? We're quiet here. And whatever it was kind of thing. I'm like, oh my gosh, let's push the curtains back. Let them talk. Because I came out of inpatient rehab. And inpatient rehab is always open floors. You know what I mean? So that's what I came out of. And as Mike will tell you, I'm loud, right? And I'm loud and I'm more like yell across the room kind of person. So it definitely, these types of settings, it's fun for the people that work there. And it's absolutely fun for the patients.
That's awesome. Yeah. And that setting up the environment plus other insights and concepts that you've shared around this more holistic approach, how to structure plans of care. People listening to this, I think, have already gotten a lot of value and may have a couple action items they can take, today. And I imagine there are some who are listening and thinking, I'd like to learn more from Mike and Coleen and more about this AMI model. So for anyone who's interested, can you just share a little bit as we wind down here? Share a little bit on, the education you provide, what your actual offer is at Advanced Medical Integration.
Sure. We created systems years ago for all of our businesses. We spent 2 years actually writing systems while we owned one practice, and I was not actually treating in it. I was just going up there to write systems. I was flying from Georgia to Pennsylvania to do that. We wrote up all the systems, but then we put together 3 clinics for, like I told you very quickly, in Tennessee. We opened those clinics based on those systems. We would spend time and energy training them, and those systems were for our clinics. We had a tragedy with a family member getting addicted to an opioid that was prescribed to them, and that was our eye opener that we have to get the word out faster. So we had no clinics in the state where they were in New Jersey. So what we did was we started AMI the following year and basically started teaching our model to other people. That's what we did. So we do live trainings monthly here at our facility. We have the 6th floor of a bank building, and behind me there's a whole classroom, and then there's a mock clinic on the other side. Our staff is lined up on this side where they're doing their job on the phones. So we do live trainings every month, one weekend a month. We do live virtual trainings like we're doing with this right now on Zoom, 4 times a week with our clients. And then we have systems on our website, it's like our portal, that they can access 24/7 to train their employees. So our trainings are not just for the owners, it's for the owners and the employees. And we actually do a lot of role playing, and we give the basics of how our systems work. And that's how we deliver it to our clients.
Awesome.
Yeah.
And if people listening to this want to learn more about that, what's the best way to connect with you? Is it going to the website? Is it?
Yeah, amidoctors.com, or if they type out Advanced Medical Integration on YouTube, we do a lot of content on YouTube, free YouTube content that they can get. And there's a lot of contact information on YouTube as well. So that's the best 2 ways.
I said, if you watched our whole YouTube channel, a lot of our program, you just got to watch the whole thing. It's a lot of YouTube videos, but we do there's a lot of content on YouTube. Yeah.
So it's Advanced Medical Integration.
Or if you go to amidoctors.com and you click the button on there, somebody's like, boom, like that gets back to you. The email. I mean, you click for more information.
Awesome. And I like that. That's a very, very evolved business model. I think, to give away the information and sell the implementation to be, like you said, people can go to your YouTube channel and just even on this podcast, to be able to learn that. And then for people who want a little more coaching, hand-holding, specificity, et cetera, to be able to have the coaching is super valuable. And Dr. Mike and Coleen have graciously offered a discount for NeuFit Nation members here for our community. So if you are interested in learning more, please do reach out to them. And I've been very impressed with this. I've gotten to have a few conversations, learn more about what they're doing, see some of the practices in action. And it's just a wonderful model. I wholeheartedly agree in and support what they're doing. And final question for you. I'll ask each of you if you could shout one message from a mountaintop for everyone to hear, or put one message on a billboard for everyone to see, what would that message be?
I got one. Do you have one, Colleen?
I do. You do yours. That's it.
All right. Mine would be, if you're going to do healthcare for yourself, you're going to try to repair your health, do it from a functional approach, not a symptomatic approach. You'll get better results.
Good.
Yeah. Mine is be part of the solution.
I love it. Two very powerful notes on which to end this conversation. So Mike, Colleen, thank you both so much for not only coming on the show, but for the work that you're doing to really help create a new paradigm that I think we all really know is a much better solution than many of the things out there. And you are definitely part of the solution. So thank you both. Thank you, everybody, for tuning in.
Garrett, for having us.
Yes. We'll see you on the next episode of the Undercurrent Podcast. Bye, everybody.